Welcome back to Close Up. There is a lot of hunger out there for facts and information in this pandemic about the virus and what the future could hold for the Granite State and the world. This morning, we're joined by someone with years of experience in studying infectious diseases to try and answer some of the most pressing questions out there. Dr. Antonia Altomare from Dartmouth-Hitchcock Medical Center, thanks for joining us.
Thank you for having me.
So I've always really liked this analogy of epidemiologists as detectives on the case trying to solve a mystery, essentially. So after a couple of months of tracking this suspect, COVID-19, what do we know about the killer and what have we learned so far?
Yeah, so I think there's a lot we still don't know, and just like every novel infectious disease, there's much to be learned. We tried in the beginning to extrapolate how does this act compared to other viruses that we know more about, and we know a lot about influenza. It's been around for hundreds and hundreds of years. In fact, we tried to figure out, based on the 1918 Spanish flu, how we can predict this acting, but this isn't influenza, it's a coronavirus, so it is slightly different. And so we rapidly started to realize how this was being transmitted, how is it different than some other viruses that we know about, and what we don't know. So are there other ways that it's being transmitted? Why is it making people sicker than influenza and other coronaviruses? And then, of course, the age-old, how do we treat it or how do we prevent it is still to come.
What's your read on the epidemic curve here in New Hampshire? We've been on this plateau based on the limited testing that is out there. How long would you expect that to last, and when should we start to see maybe some more of the effects of the social distancing and the stay-at-home order?
Yeah, it's a complicated question, and I love using the quote of George Box, famous statistician, that all models are wrong and some are helpful. Because as you've probably seen in the news, there's a lot of different models being used, some out of the University of Washington, University of Pennsylvania, and the output is only as good as what you put in, and there are many, many, many variables that get put into these models that can change it dramatically, and a lot of it's based on assumptions and predictions. And we've been using a model of our own that changes day to day based on what we're actually seeing. So we're trying to put as much realistic and factual data into it. And as you've probably seen with the New Hampshire curves that are coming out, some are saying that we've already peaked and we're on the downswing, and some are saying the peak is yet to come. And so I think we're somewhere in... Yeah, go ahead.
No, I mean, continue. We're somewhere, the crucial part there.
That's right. So we're somewhere in the gray zone, and I think the biggest effect that we're seeing is the social distancing, and the farther out we get and the longer we stay isolated, the more impact that's going to have on the long run. And I think we do have to be extremely mindful of what happens as we start reintroducing people into society, and there's this three-phase approach for doing that. And if we do it too quickly, we are kind of bracing ourselves for what might be this second swing or this second peak of increased cases.
We'll get more to the reopen in a little bit. I'm curious, so at Dartmouth, you guys were able to stand up a testing regime a little bit more quickly than the state and other groups there. Tell us how you guys were able to do that and how that continues to work to this day.
Yeah, so we're pretty proud of our ability to test and have a really quick turnaround time. We had actually developed our own test in-house. The turnaround time at this point, you can get a result within a day or two, and we know that this is a little quicker than what the state had been doing just because the volume of specimens they were receiving. And so we have a drive-by testing clinic that's staffed by our own nurses, grabbing specimens, running it to our lab, getting those lab results out, and then a whole hotline of nurses that are calling each individual patient to let them know of their test results.
So what is exactly standing between us and mass testing as a country? Is it cost? Is it capacity? From a medical perspective, what's standing in the way?
There's actually a few things that have been limiting to this entire process, and it all had to do with supplies, not just the testing supplies, but the appropriate protective medical equipment to obtain the tests. And as you know, we've been short on PPE for some time, but we also know that we've had several flight deliveries of PPE coming into New Hampshire, which has been great. The other thing to know is the transport media. So what the swab gets put into to get to a lab is made in Italy. And so when Italy was having their crisis basis. The manufacturing of that went down, and we've actually been validating what we call dry swabbing, so being able to take a specimen and not relying on a transport media, and so validating that on our test machines to make sure we can get reliable, accurate results from there. The other piece to that are the swabs, so availability of swabs, and we had kind of dabbled in whether we can create or manufacture these swabs in a novel engineering type way. And so it really comes down to the supplies, even the supplies potentially to run the actual test in the laboratory.
And historically, when you've game planned these kind of pandemics or done tabletop exercises or things like that, was it ever the plan to have this sort of 50-state approach where each individual state is in a mad dash for PPE and supplies, trying to work on its own, do the social distancing order in different ways? Was that the model for how this was supposed to go?
Yeah, so I don't think anyone was truly prepared for a pandemic. I think we prepare and we train and drill every month for an epidemic or an outbreak. We've had to deal with several of those, and we were ready when Ebola started acting up in the Democratic Republic of Congo, based on our experience in West Africa several years ago. So we were ready, but I don't think you're ever truly ready until it hits. And I think, the strategic stockpile that our government has is helpful, but to a certain extent. And then individual states are supposed to have some supply, pandemic supply, and when it actually happens, it seems that it's never enough for what is actually occurring. So what's happening in New York City is probably something they never thought would happen in a lifetime. And here we are, and we're getting through it as a nation and as a state, and we're doing the best we can under the circumstances.
You had mentioned earlier the phased reopening. What's going to happen in Georgia? The governor there is just basically going all the way in and trying to reopen the economy quickly. Is it any question at all what's going to go on there with the virus? Are we going to see an automatic resurgence there?
Yeah, I think it's pretty predictable that when you have people in isolation, virus is circulating at a certain level, and the more people you reintroduce, the more cases you're likely going to see. And so if you do it all at once, there may be this bigger surge than if you do it slowly in waves.
And when you mention that phased reopen, does that make sense from a medical perspective as well? Obviously, people want to get back to work, but does it make sense to have some people out there who could be asymptomatic carriers going around and then try to segregate a different part of the population? Will that actually succeed?
Yeah, so I think the idea behind this phased approach is really, one, getting back to accomplishing some amount of herd immunity, which we hear about in the vaccine world. And unfortunately for COVID-19, a vaccine is in development, but we're talking 12 to 18 months from now, and obviously we can't wait that long to get the economy back and going again. So the more people get infected, the more have been exposed. The question that we still haven't answered yet is whether that exposure confers immunity through natural infection. And there's studies now using antibody tests to really figure out, well, if you have an antibody, does that mean you're safe and immune and will never get infected again? And if so, it'll be a lot easier to, in a rolling fashion, kind of test populations and get them back into their workforce, knowing that they're safe to be there and they're likely not going to get infected again or transmit virus again. I think the way that it's going to look in reality is that we may be masking, that may be part of our culture for a long time, meaning months and months down the road, until we know that we have a way to protect the majority of people.
You mentioned antibody testing there. The LA County Health Department and USC just had a study that indicates that people in California, more than they had estimated, they thought had COVID-19. What's your read on that study, and what could that tell us about what COVID-19 is doing in terms of prevalence?
Yeah, I think, I've always had a suspicion, and again, my opinion is that this was probably here longer than we thought, and there probably are many more people infected than we initially thought, because as we're learning more about the virus, there's many more people that are completely asymptomatic, meaning they're not developing symptoms and are carriers of the virus. So they've been infected and they can transmit, and it goes away and they never even know about it. And so I think it's very interesting, and I think these point prevalence surveys or this testing antibodies really is a good way of knowing, well, how many people in this population have really been infected, and what does that mean for us going forward?
So you're a smart person, so you probably don't spend a lot of time on social media, but on those platforms, there's a lot of folks who will just say, this is all just a bunch of hype, oh, it's the flu. How do you respond to those people?
Yeah, I think it's really hard because there's a lot of misinformation going around on those platforms and others, and it's really hard for the end user to discern what's real news and what's not real news. But we know genetically by looking at this virus that it is not a flu virus. There's lots of influenza-like viruses, and this one isn't one. It's a coronavirus. We know that through its genetic sequencing and the way it's behaving. So I think it's important to know that we can take steps, and it's acting a little bit like influenza in the fact that you can shed it when asymptomatic and it makes you ill. But it's certainly making people more sick than we know influenza to do. But again, when it comes to numbers and not knowing that denominator, we also have many more people infected with flu in any given year that we usually don't know about because not everyone's being tested.
You mentioned not having enough information yet to make a clear judgment on this. When do you think we will have the kind of numbers, the data there to more accurately sort of say what's going on with COVID-19?
Yeah, I'm hoping that with these ongoing serologic studies, so those antibody studies, we're going to know more information quickly about what it means for true immunity and protection from the virus. And then I think from there, we're going to incorporate that test modality into getting people back into the workforce and coming up with procedures on how to kind of make this part of life, at least for the next months to years to come, because this virus is going to be here in our population for some time. It's going to take a while before we're kind of as business as usual, and what usual is probably not going to be what we were used to. You know, in December. I think life is going to look very different going forward. But I think the more we know, the safer we can be about it, and the more prepared we'll probably be for the next time this happens.
Okay, Dr. Antonia Altomare, thank you for sharing your expertise from up there in Hanover. We appreciate your time.
Thank you very much.